Welcome to This Week in Rheumatology. This week we are covering 10 notable papers spanning 3 broad themes: novel therapeutic pathways and real-world outcomes in vasculitis and autoinflammatory diseases, optimized screening and patient-reported measures in myositis and lupus, and the broader clinical and socioeconomic context of chronic rheumatic care. Let us dive in. We begin with major clinical insights into vasculitis management, starting with real-world evidence for avacopan in anti-neutrophil cytoplasmic antibody-associated vasculitis. In a retrospective single-center study, researchers evaluated 35 patients with new-onset or relapsing vasculitis who received avacopan alongside standard induction therapies like rituximab, cyclophosphamide, or both, comparing them to 70 matched controls. Although the avacopan group had more severe baseline kidney impairment, with a median estimated glomerular filtration rate of 24 milliliters per minute compared to 49 in the control group, the results were highly encouraging. While remission rates were similar at 6 months, they tended to be higher with avacopan at 12 months, reaching 86% compared to 68% in the control cohort. Most notably, the relapse rate was drastically lower in the avacopan group, at 16% versus 51% in controls. Avacopan also successfully facilitated accelerated glucocorticoid tapering, with patients reaching 5 mg or less of prednisolone per day in roughly 100 days, compared to 164 days in the control group, resulting in a significantly lower cumulative steroid dose. Renal recovery was also superior, showing a greater improvement in estimated glomerular filtration rate after 1 year. However, clinicians should remain vigilant as over a quarter of patients discontinued avacopan due to adverse events. Staying with vasculitis, diagnostic delay remains a major hurdle in large vessel vasculitis, as highlighted by a retrospective study from a tertiary German rheumatology center. Looking at 501 patients, including 488 with giant cell arteritis and 13 with Takayasu arteritis, researchers found a stark difference in the timeline to diagnosis. The median time to diagnosis for Takayasu arteritis was 245 days, nearly 3 times longer than the 89 days observed for giant cell arteritis. Patients presenting with typical cranial symptoms experienced a significantly shorter diagnostic interval. Conversely, involvement of the aorta and its major branches was linked to prolonged delays, with a hazard ratio of 0.64. Interestingly, prior consultations with rheumatologists were actually associated with longer diagnostic delays, whereas referrals by ophthalmologists and cardiologists were associated with earlier diagnosis, demonstrating hazard ratios of 2.4 and 3.81 respectively. This suggests that atypical non-cranial presentations often baffle initial providers and emphasizes the need for broader clinical education to suspect large vessel vasculitis when classic cranial symptoms are absent. Moving to other targeted therapies, a phase 2 open-label trial published in Annals of the Rheumatic Diseases evaluated the Bruton's tyrosine kinase inhibitor, zanubrutinib, for active immunoglobulin G4-related disease, specifically involving the lacrimal and submandibular glands. 10 participants received zanubrutinib monotherapy for up to 24 weeks without any glucocorticoid induction or background immunosuppression. At week 24, blinded imaging showed that mean gland volume decreased significantly, by nearly 47% in the lacrimal glands and 30% in the submandibular glands, alongside substantial reductions in metabolic lesion volume and clinical disease activity. Single-cell RNA sequencing revealed that zanubrutinib modulated B-cell transcriptional programs, reduced immunoglobulin G4-skewed plasmablasts, and attenuated cytotoxic CD4-positive T cells, offering a promising, steroid-sparing therapeutic strategy. Meanwhile, in the realm of monogenic autoinflammatory diseases, real-world data from the International Autoinflammatory Disease Alliance Network Registry confirmed the long-term effectiveness of the interleukin-1 inhibitor canakinumab AB in familial Mediterranean fever. Among 158 patients, complete clinical and laboratory response was achieved in nearly 46% of patients at 3 months and almost 59% at 1 year, with more than 80% of patients completely free of clinical manifestations across all time points. Discontinuation due to inefficacy was rare, and early control at 3 months was a strong predictor of sustained long-term remission. Our second major theme focuses on optimizing risk stratification and patient-reported outcomes in myositis and lupus. We begin with a multi-center international audit, which evaluated historical malignancy screening practices in 795 patients with idiopathic inflammatory myopathy against the recently published International Myositis Assessment and Clinical Studies, or IMACS, guidelines. The audit revealed a stark gap in clinical practice, Very few high-risk, moderate-risk, or standard-risk patients underwent the full panel of recommended screening tests. Despite this underscreening, nearly 11% of the cohort developed a malignancy within 3 years of myositis diagnosis. Strikingly, over 3/4 of these cancers occurred in patients classified as high risk, and the remaining occurred in the moderate risk group, with absolutely no cancers detected in the standard risk group, strongly validating the IMACS risk stratification framework. Independent risk factors for cancer included anti-transcription intermediary factor, 1-gamma positivity, smoking, night sweats, and older age, while anti-MA2 antibodies and non-dermatomyositis subtypes were protective. Accurate risk assessment is also critical in myositis-associated interstitial lung disease, as demonstrated by a study in RMD Open that evaluated the prognostic value of chest high-resolution computed tomography. Comparing visual assessments against quantitative imaging analysis in 168 patients, researchers found that, while visual review identified interstitial lung disease in about half of the patients, neither the visual presence nor the specific radiological pattern predicted survival. In contrast, quantitative measures of lung fibrosis and total lung disease burden were strongly correlated with forced vital capacity and diffusing capacity. Crucially, higher baseline quantitative scores and worsening trends within the first 12 months were independent predictors of all-cause mortality. This highlights a clear clinical need to transition from subjective visual reviews to objective quantitative imaging metrics to identify high-risk patients early. In systemic lupus erythematosus, cognitive dysfunction or brain fog is a highly prevalent and disabling symptom that has historically been difficult to measure. To address this, a study, which is the first patient-reported outcome measure, designed specifically for this symptom, validated in a cohort of 378 patients across 36 countries, the scale demonstrated excellent internal consistency and a strong correlation with functional impact and overall symptom severity, providing clinicians with a practical and reliable tool for routine clinical use. Beyond cognitive symptoms, patients with systemic autoimmune diseases face severe long-term complications, including human papillomavirus-induced malignancies. A massive nationwide matched cohort study from France compared over 122,000 patients with immune-mediated inflammatory diseases, such as lupus, Sjogren's syndrome, systemic sclerosis, and rheumatoid arthritis, against over 316,000 matched controls over an 8-year period. The study revealed that patients with these inflammatory conditions have nearly double the risk of developing human papillomavirus-induced cancer or severe dysplasia, with significantly elevated risks for cervical, vulvar, vaginal, and anal cancers. The risk was particularly high among female patients, those with lupus, individuals under 65, and those with chronic kidney disease, emphasizing the critical need for aggressive vaccination and screening in these populations. Our final theme explores broader management paradigms and systemic factors influencing rheumatology care. First, a clinical review in the New England Journal of Medicine re-evaluates fibromyalgia, emphasizing that the condition is characterized by central nervous system hyperresponsiveness to sensory stimuli. The authors outline that successful management must focus on achieving central nervous system quiescence and restoring homeostasis through a combination of pharmacologic and non-pharmacologic strategies, such as physical exercise and cognitive behavioral therapy. While fibromyalgia is rarely curable, the review highlights that the vast majority of cases can be managed highly effectively within primary care, with rheumatologists serving primarily as diagnostic consultants. Finally, we must consider how national socioeconomic factors influence our treatment outcomes. A study published in Annals of the Rheumatic Diseases analyzed data from nearly 39,000 patients with psoriatic arthritis or axial spondyloarthritis, initiating biologic or targeted synthetic therapies across 13 European countries. The researchers discovered that drug retention was significantly lower in wealthier countries with a high gross domestic product per capita, where clinicians and patients discontinued or switched therapies much earlier. Conversely, patients in lower-income countries initiated advanced therapies at significantly higher levels of disease activity. This suggests that national economic status and local healthcare resources heavily influence both the threshold for starting advanced therapies and the ease of switching between them, a factor that clinicians and policymakers must keep in mind when interpreting international clinical data. If you only have time for one paper this week, make it the real-world comparative study of avacopan in ANCA-associated vasculitis. This study provides vital, real-world confirmation of avacopan's steroid-sparing efficacy and its ability to drastically reduce relapses and improve renal recovery in patients with severe disease, offering immediate practical guidance for our daily clinical decisions. Here are the key takeaways from this week in rheumatology. First, in ANCA-associated vasculitis, real-world data confirm that adding avacopan to induction therapy significantly reduces relapses, enhances renal recovery, and dramatically cuts cumulative glucocorticoid exposure, despite a high rate of drug discontinuation due to adverse events. Second, the newly validated lupus brain fog severity scale offers a highly reliable patient-reported tool to measure and track cognitive dysfunction in daily clinical practice. Third, patients with systemic autoimmune diseases, particularly lupus, face double the risk of human papillomavirus-associated cancers, demanding aggressive vaccination and screening strategies. Fourth, quantitative chest-computed tomography metrics, rather than visual patterns, are the key predictors of mortality in myositis-associated interstitial lung disease and should be integrated into high-risk patient assessments. And fifth, national socioeconomic factors heavily influence biologic drug retention and disease activity thresholds, with wealthier nations showing earlier drug switching and lower-income nations initiating therapy at higher disease activity levels. That's your roundup for this week in rheumatology. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And for audio briefings on your own clinical questions and papers, visit audioscholar.cc. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.